So my job then is to talk just a little bit about the opioid crisis, talk about the Colorado Alternative Project, and then really introduce and be sure we are on the same page as far as what Iroquois is trying to do with all of our partner hospitals. So all of you, of course, are familiar with the opioid world, having lived in it and living in it every day. And this is data from the CDC just to illustrate a couple of the key facts and statistics. We all know that people are dying every day from opioids, that there are people who are misusing opioids every day, that most of us probably have at least one opioid pill in our medicine cabinet at home. Come on, be honest. Okay, some of you. And that there are lots of reasons for the opioid addiction, and it has both a huge human toll and a huge financial toll in the U.S. today. It's certainly in some spots more than others, probably in urban areas more, but no part of the country is really immune from being part of the opioid crisis of the last few years. And this is a CDC map from 1999 and 2016, which shows age-adjusted death rates from drug poisonings, including opioids, by county. And you may not be able to see the legend on the bottom, but blue is not so much, and red and orange is more and more in lots. So you see a huge change in the map overall. You see some of the hot spots of drug use and opioid use over that 16, 17-year period. And you see that the entire country's map has changed. It's not just in one place. So there's no question that because of that, opioid prescribing, opioid use has been something on the minds of lots of folks. And what we're really trying to do, and I know many of you have already started doing this and are doing it, is changing the culture of providers as far as how they approach and how they use opiates. And we're going to try to slice into just a single segment of that activity. But that really is the goal. It's not to do what Iroquois tells you or what your medical director tells you. It's really to try to change the culture of how we treat patients so that we can reverse some of the problem that we see. This is CDC data from March of this year, and really just to illustrate the point that despite the efforts that have been ongoing, and there are many, we still continue to see some increases in opioid use and overdose in certain parts of the country. The Midwest, of course, has been a real hotbed of bad opioid use. And then certainly in the large cities, we continue to see opioid use and abuse. One of the startling things that I think recently is that the U.S. life expectancy dropped this year, and it dropped for the first time in a long time from 16 to 17. And you see that in the top bar, and you see it for almost all the ages, but overall, U.S. life expectancy dropped between last year, between 17 and 16, almost exclusively because of heroin and opiate overdose and death. That's a pretty startling figure, that it is so widespread that across the population as a whole, we've reduced life expectancy in the U.S. So how do we get here? Well, one of the things, and I think it's true as emergency physicians and emergency departments and emergency nurses and providers, we often say, well, we're not the problem, right? It's all those drug mills and those drug-pushing doctors and people in the community who give out, 90 days worth of pills without even thinking about it. And there's probably some truth to that. On the other hand, I think we've all reached the point where we all have to say we have to accept some responsibility for that. Clearly, having pain pushed upon us and being hospital-based providers, it's pushed upon us more than the community providers of fifth vital sign and everybody having to leave with a number 10 smiley face in their chart from the Joint Commission, kind of slowly and I think insidiously kind of created a behavior that maybe was unintentional. And I think we just have to recognize that and recognize that some of that's reversing now. There's no question that we underappreciated as a community the addictive potential, particularly of the new prescription drugs. And I think maybe in two ways. Some of us, I said yesterday, some of us are older, and we remember the days when you gave Tylenol, and if somebody was really hurting, you gave them Tylenol number 3. And if they were really, really hurting, you gave them Tylenol number 4. And then you were done. You had nothing else to give them, okay? Now, I understand most young practitioners don't even know what Tylenol number 3 is anymore because we're now in the world of oxycodone and Vicodin and OxyContin, et cetera. So as a result of the changes to how drugs are made And then the aggressive marketing of those, we've kind of changed and thought, here's a new class that's better than what we used to have, that's non-addictive. And I think, unfortunately, the world at large bought into the maybe non or not so much addicting potential of those drugs. The other thing that I think we've discovered in this discussion is the harm that we can do by giving even a little bit of opioid to an opioid naive patient. So the person who's in our department, even with a real need for an opioid, who gets the opioid for the first time in their life, we always thought no big deal, we're healing their pain. But the big deal is that a small but real percentage of those patients, even with single doses or one prescription, ultimately become abusers and addicted folks. And so that's a realization that I think many of us probably didn't have. There's no doubt that there are people out there who inappropriately dispense, whether intentionally or not, too many prescription drugs in the past and even currently. Sometimes for convenience, you're much less likely to get a call from your post-op patient at 2 in the morning if they had 30 days of narcotics instead of 3 days of narcotics, and I think that's something that's changing as well. So I think the message is there's lots of reasons. That means there's no one solution, and everybody, including people in this room, are to blame for at least a little piece of the problem. And I think many of you and all of us have recognized that. There are a lot of things that have already been done, and it's important to understand those to put the Iroquois Project in the right context. So the Iroquois Project is not intended to replace, to minimize anything that you're already doing or planning to do. It's meant to be one more slice in the project of an overall kind of opioid reduction program. So we recognize that New York State and others have put in place some sorts of roadblocks or speed bumps for people who want to prescribe opiates, and so understanding a patient's opiate history before you prescribe more. Many states have put in limitations on the length, the duration of prescriptions, or the number of pills that can be provided to patients. Certainly there's been a change since I practiced in the ED a number of years ago of identifying people who need opioid treatment and doing Suboxone, finding places for them to be when they leave. So oftentimes people can leave now with more than just sympathy from a provider. That's very helpful. Clearly Narcan, on the one hand, has saved people to be opioid addicted and overdosed again, and on the other hand, clearly is a life-saving medicine. As Iroquois kind of queried all the hospitals and said, what have you done, what are you doing? The kind of relationship to outside clinics and treatment links from the ED directly into the community where they exist has been something that's been pretty widespread for most of your hospitals. And then lastly, I think even before this project, and now we hope through this project, some additional attention and kind of more protocol or guideline driven use of alternatives to opioid in the emergency department. So the Iroquois Project is really about just that last piece, which is, when a patient is in the emergency department with you, could we do something that would help reduce the likelihood that they would get a narcotic while they're in the department with you? Now, theoretically, if we can do that, we might decrease how often you give them a narcotic when they go home. But the primary goal is really not about prescriptions, it's not about Suboxone, it's not about mental health clinics, it's really about that specific slice of could we reduce use of opiates in the emergency department by you all creating a set of guidelines for us and then us helping you kind of infiltrate your system so that they get pushed down all the way that they become everyday treatment. Now, when I first started to think about this with Iroquois, I went to a couple people and I said, is Iroquois too late in the game here? Have you all changed your practice now so that you're all doing this and every patient that has pain, you're thinking, oh, what could I give them other than an opioid? And I think the answer I got was not yet. So while many of the things that you may see and the protocols, you may say, oh, we already do that, or I do that as an individual practitioner, it's pretty clear that the culture hasn't completely shifted yet. And so the goal is to move you from doing generically doing kind of some of the right stuff most of the time to doing all the right stuff all of the time, okay, if that makes sense. So we think it's still a useful push even at this juncture in trying to fix the opiate stuff, okay? The program is modeled after a program that was in Colorado, and I would urge you all to go to the Colorado website, which is Colorado Hospital Association, so it's CHA.com. They worked over a longer period of time than we have the luxury to do with this being a state grant, but they started with the Colorado ACEP chapter, And Colorado ACEP developed a set of treatment guidelines, and it's fairly extensive and well documented set of guidelines. And then through the Colorado Hospital Association, went to 10 hospitals to start. The participation was voluntary. They were in kind of a segregated region, although there was some urban and rural hospitals, based on the Colorado guidelines. And they, through the Colorado Hospital Association, did the training and kind of the help to push for the data collection. And they had an aim at the beginning of their project, which was to reduce the administration of opioids by 15%. And they measured in morphine equivalents. So it wasn't just how many patients got it, it was trying to put morphine equivalents over a 6-month period in 2017. And their results were even better than they had expected, I think. And this just shows for a number of disease categories. This is 2016, this is 2017. And the blue bar is the percentage of patients that got administered an opiate. And in those 2 years, the green is those that got alternatives to opiates.
I'm Bill Paulo. I know a lot of you out there. This is Ross Sullivan. We'll be chatting with you a little bit about what we've worked on and what you guys have worked on and the effort that's been put in, and try to sell you on what we intend to do with this. This is a cultural change, and cultural change takes time. It takes a long time to see the benefits of what we're doing. Right now we're looking at little changes. We're going to talk a lot about what we think are frontline agents for a lot of the painful conditions we're talking about, and why we want you to look at opiates as rescue medications rather than frontline medications. We're not telling you don't ever prescribe opiates. We're not telling you don't ever give opiates in the emergency department. But we're trying to reduce the frontline way in which you use it, knowing that the data is pretty convincing for almost all the conditions that we chose, that opioids are no better, also no worse, than any of the other medications that we're going to tell you about, with less of the side effect profile in terms of addictive potential and potentially reducing the amounts of opioids that you prescribe later. When we went through this, we stayed away from some things that we thought were particularly controversial. We didn't put in cancer pain, because I don't think any of us will begrudge you giving all the opioid equivalents and morphine equivalents that you want to your cancer pain patients. I certainly do. I tell my residents you have carte blanche to make this person in as least pain as possible. We're not doing that. But when we talk about dental pain, the evidence is pretty clear that acetaminophen and ibuprofen are no better and no worse than opioids, which means that opiates are no better than acetaminophen or ibuprofen. So that's what we want to change. Again, it's a cultural shift, as we talked about. Some of the barriers, and we'll get to these in a little bit, are going to be, yeah, doctor, now you're telling me I waited 6 hours and you gave me a Tylenol? Yes, that's exactly what we're telling you, and that's exactly what we aim to do with this. It takes time, but what I will say on a positive end before we get into this a lot is, actually for the first time over the past 6 months in my practice, and I don't know if this has happened to you, I think the spreading of the opioid epidemic and the awareness of it has gotten to the point where now when I talk to people, I actually have patients saying, I'm worried if you give me morphine, I'm going to become pain addicted. And I think that's a complete shift. So what we're doing here is the same thing. We don't want to make people phobic, but we want to understand that what we've done as a house of medicine and what we've done to our patients and what we've taught them to do takes a while and a long time to undo. And this is one of the first steps, so that when they come in, it isn't, I'm not going to treat your pain because I don't think highly of you and I'm only going to give you ibuprofen. It's, I'm going to give you a pain medication that does the same thing that it does, but I'm also going to reduce the harm I give you as well. So this is what we want to do. We want to give you some historical context. We're going to break things down. I'm going to talk a bit about medications and things. Ross is going to talk about harm reduction. We're going to kind of tag team this back and forth so you understand what we're talking about and what we're looking for. And at the end, we're going to get into the protocol sum. So here's our goals. It's a long step goal. Our little changes that we're making here, and these are really minor changes. Dr. McCabe referred to these as guidelines, and I think that's the best way of looking at them. We're not dictating to you or your providers how to practice medicine. We would never do that. Much like an Ottawa ankle rule or anything like that, it's a guideline. I have many people that have failed my ankle rules that I've gotten x-rays for anyway. It's a decision instrument. These are advisements. These are ways that we think are best managed given the state of medicine in 2018. So we want to develop a strategy. We want to identify the barriers. I'm aware of a lot of them already from just our brainstorming, your discussions. I know that Iroquois is going to use a lot of what we talk about today as advocacy in order to make changes at the state level as well so that we can do this. So The pillar of this whole thing, or the foundation of this entire concept, is that when we reduce opioid equivalents in the emergency department, we reduce potential addictive behaviors afterwards. In addition, I would tell you that if that was in and of itself, I would be behind it. I would be all for it. But what I would also tell you is that almost all of the diseases we've chosen, the medications that are on our list, don't do any worse than opioids, and certainly have less addictive potential and side effect profiles than do the opioids. And that's why we chose them too. It's not just because we want you to be opiophobic or pain phobic or go back into what was the bad old days when we didn't treat pain or what have you, or whatever led us to here. But what we're also saying is not only are these medications potentially abusive and associated with harm, as we all see in our emergency departments day after day, but we also have medications that do just as good a job. So if there is a medication that does as good a job and it reduces the amount of harm that we're doing, then we err towards that. And that's what these guidelines are. What we're trying to do is limit opioids from the ED. We're trying to change cultures. We're trying to change what people believe. What do your people believe? I get good Press-Ganey scores because I gave you morphine because it meant I cared. I know that I have colleagues, they order all the tests in the world. They get great Press-Ganey scores. I tell people they can't have things, I get worse Press-Ganey scores. I get that. It's hard. It's a cultural shift. It's much easier to be the doctor that clicks off on things. I know this. I have a kid that comes in from urgent care, hit their head. Urgent care said, you got to get a CAT scan. I see the kid, I don't think he needs it. It takes me 2 seconds to click. It takes me 20 minutes to talk about how you can trust me with your child's life. So same thing here. People believe that there is real pain medication and then just that junk you can buy over the counter. And there's a lot of junk you can buy over the counter, but not infrequently that junk is just as good as the thing I put in your IV. Right? And so that's what we're trying to do. We're trying to reduce this. And we're also, and Dr. Sullivan will talk about this because this is his wheelhouse, we're also trying to establish programs where we're reducing harm by having harm mitigation through opioid therapy and opioid sparing therapy, something like buprenorphine clinics and bridge clinics like what Dr. Sullivan does. All right, so we know all of these things. We fail at a lot of these things, right? We know this. These are the barriers that we do. Technically, if we're going by the book, I should come up to you and I should do a risk assessment before I'm giving it to you. I should ask about your addictive behaviors. I would tell you that the PMP, however, is one of those things that I do check regularly. A lot of these things I don't do, but the PMP is something I'm doing pretty regularly with my patients. And it's one of those things I was extraordinarily resistant to once upon a time when it was put upon us. And I thought, this is another thing, another bureaucratic level of practice that drives me insane, and I'm going to hate, and I now, however many years on, and this is one of the best things in my practice because I can really tell what's going on with my patients and what I'm concerned about. So do we continue to do this? Low back pain, headaches, that's what we're going to talk about. We're focusing on low-lying fruit in these protocols. This is not cancer pain. This is headache pain. This is low back pain. This is dental pain, renal colic. A lot of things that we have good established medical care for that could potentially reduce your opioids. In addition, Dr. Sullivan is going to talk about ketamine some. Again, no vested interest. But even if you don't have the be-all, end-all with ketamine and just getting completely pain-free with subdissociative dose ketamine, there's good evidence out there that subdissociative dose ketamine and numerous painful conditions, including renal stone pain, fibromyalgia, sickle cell pain, actually has reduction in opioid equivalents and morphine equivalents. So what we're trying to do, again, is reduce that. That's the big thing here. We're trying to reduce the amount and look at it as only rescue medication in those that failed, that which is established as frontline, which is what we're discussing here today. Our principles are that all of the opioid-sparing medications are the go-to medications as frontline. These are the medications that we should be utilizing in these select conditions as frontline. We left some things out there. One of the things that we did not put in were long bone fractures. A lot of us get QI'd on long bone fractures and time to pain medication, and there's a lot of vicissitudes with our hospital accreditation and whatnot looking at that. So to mitigate for that, we just left that out. We did put in musculoskeletal, which we're primarily looking at sprains, strains, and back pain and things like that. And we're aware of some barriers that you'll have even within the things. We talk about lidoderm patches. And we know that lidoderm patches are great. I can give them in my emergency department, but for some bizarre reason require prior authorization and cost you like $100 for a 5-pack, and you use 2 of those a day. So we're aware of all of that, but we're trying to work within the means of what we have, and we give you multiple alternatives in these pathways as well. These are suggestions. and to reduce what you have to do. So we have these specific pathways. We're trying to do multimodal pain, kidney stones, back pain, fractures, headache, and chronic abdominal pain. We have abdominal pain on here. Mostly we're focusing on the chronic abdominal pain. Again, I think what's happened is we've done this grand experiment in a way where we've had a lot of people that have come in with diseases that I didn't train on in medical school, like cyclical vomiting syndrome or cannabinoid hyperemesis syndrome or abdominal migraines, these things, that we now have medications that we see over and over again, things like haloperidol and things like ketamine take away this discomfort. And so we're saying there's good evidence that it works for this, and it may work if we look at it in other abdominal pains, but we're at least here focusing on chronic abdominal pain. We don't say, hey, you have a person that comes in and they perforated their ulcer and they have frank peritonitis, Toradol. It's not what we're, for multiple different ways why we're not saying that with your perforated ulcer. But we're trying to say there are certain disease entities that are very amenable to it. And what we looked at when we kind of honed this down with the group, we looked at very low-lying fruit here. So honestly, one of the barriers would be this requires more patient engagement. It requires you to discuss with people. Somebody yesterday in the Capital Region asked me, well, if I go in and I see somebody and I tell them, here's just some ketamine, how do I do that? How do I set that up? How do I make it such that they're going to understand that I'm still caring for them? And we're working on potentially scripting some things for you, and I'll tell you guys the same thing I told them. I'd say the same thing with all pain medication I tell everybody, right? It's the same thing I was taught when I was working, when I was in college and I was working at the Wiz, and they told me how to sell extended warranties. I do the same thing, is I have a great medication, and it works for everything, and it's gonna make you feel so much better. It works for all, even if you're bleeding in your brain, it's gonna take your headache away, for goodness sake. So I know you're going to, so I do the same thing, because pain is multimodal. It's both a physical component and there's an emotional component. And the time spent at bedside caring for somebody and telling them about how you're still concerned about them, it's not, I'm only going to give you, therefore, ketamine. I'm only, therefore, going to give you Toradol. It's, this works for your particular disease entity, and I know you're going to feel better because I've had it work before. It's a cultural change. People are going to be resistant. People expect a certain way that they work. You come in and you care about me a lot because I have bad pain. That's an opioid. You don't care. You gave me ibuprofen. And what we're trying to say is that it takes a long time to change a culture. You're starting to see some of the nidus of that now, but it will take even longer. So that's what we're looking at.
These are pain receptors, basically, and these are, afferent and efferent, receptor system. And basically, what I'm trying to show is that pain's complex, right? There's a lot of receptors that are involved in pain, and opioids not the only one. I mean, it does work, but we tend to think that opioid is, that's what we do for real pain. But in reality, there's quite a few receptors that are all engaged in some type of pain or pain modulation, and we have written here some of the other medications that work on these certain receptors. And those of you who are involved more in pain or psychiatry or pain medicine or addiction, often these are what are used, right? Like TCAs and carbamazepine and gabapentin and so on and so forth. There's a lot of other medications. And it's time, for us in the emergency department, maybe not to use all of them. I'm a toxicologist and have a stroke if everyone was using amitriptyline for pain. But I guess would keep me in business. But the good news is that, that there are a lot of other things that we can do. So we're going to talk a little bit about some of the medications that are on this list. Some of them we use all the time, some of them not enough. And what we're talking about really, if you look at these protocols that we have, is that they rely heavily on acetaminophen, ketamine, Toradol, or ibuprofen. We put Haldol on there because Haldol is not heavily involved, but it is on the protocol, so we will have a little mention about Haldol. And then gabapentin we'll talk about as well, briefly, for some of these protocols. So ketamine is an NMDA receptor antagonist, and the toxicologist in me will tell you that it's the little cousin of PCP. That shouldn't scare you. And that's important because PCP originally in the 30s and 40s was used as an anesthetic. It was used for anesthesia and people and in the battlefield. But then people found out that when they were waking up for anesthesia, they were just like crazy. So they didn't do it anymore, obviously. But then ketamine was synthesized, and the potency of ketamine is much less than PCP, and it actually has all the good properties that which PCP was first originally thought to have. And that is that it does analgesia, it does anesthesia, and amnesia. Right? It's like one of these really good drugs. It kind of does all these different things. And most of it's modulated by the NMDA receptor, and that's kind of making it simple, but that's how it works. And what we know that at low doses, we've talked about the subdissociative dose. So that's before you have this huge dissociative kind of high or low, is that it works for pain, and it works really well for pain. Now, it can be given a lot of different ways. It can be used, most of us are familiar with it, intravenously for sedation. So you give 0.5 or 1 or 2 mg per kg, slow IV push, and it causes anesthesia, right? Amnesia, and all these other things. But at a lower dose, it doesn't cause anesthesia or, frank sedation. It causes some decreased pain. And it can be still given intravenously. It can be given intranasally. Now, I've not used it intranasally. I know some of my pediatric people have, and you can use it in the same way that you give anything intranasally, like Versed that we use. You can also give it sub-Q, which is not on here. I've given it subcutaneously several times and many times for pain. And it says here PTSD is a contraindication. So I guess if someone has a frank, really severe PTSD history where they're constantly having PTSD reimmersion type of symptoms, maybe you would not use it. But if someone says, oh, I have PTSD, but they're okay, I would use it. But as for the really frank, psychiatrically ill PTSD patient, you really shouldn't use it. It's safe. All the stuff that we talk about, like we talk about, what about this intracranial blood pressure? Well, that's not even a real thing, really. What about laryngospasm? It does happen. 1 to 2 mg per kg normally, or higher. So laryngospasm is really not too much of a worry for this. And I believe in the Colorado stuff, at the low dose ketamine, there was virtually almost no laryngospasm at all at these low doses. So it's very safe to use. You guys already know a lot of this. The recommended dose here is 0.2 mg per kg. And Bill and I recommend a lot, putting it in a 50 ml bag and having it run maybe over 15 minutes. It's also an advocacy thing. In an emergency department, we should be using ketamine and should be allowed to use it. So not only is it important for this project, but it's also important for our patients and the profession moving forward. 50 milligrams intranasal can also be given, so if someone can't get any access, you can give it to them intranasally as well. Sub-Q has erratic absorption, which is why it's really not recommended in this protocol. Not great for pain. And you can use it. If you had to use it with opioids or other medications, it's really safe because it has its select NMDA receptor antagonism, so a lot of other medications we give don't work on that receptor, so it's safe. Ketorolac, so 15 milligrams for everyone. What we do know is that 15 milligrams right now versus 30 milligrams, there's no difference in pain. There's actually not. Maybe 15 now and 15 in a couple hours, there's a difference. It's like we talk about ondansetron or Zofran. No study has ever shown that 4 versus 8 right now makes any difference for nausea. It just doesn't. But 4 now and 4 in a couple hours might, right? So we do recommend giving ketorolac for a lot of these things that you'll see, 15 milligrams IV or IM. You can give it to people who have borderline creatinines. You can do it. It's okay. Someone says, I once had an ulcer 20 years ago, so it's on my allergy list. You can give it, and you can do it. And it's really great because not only for its pain properties, but we also talk about things that have some prostaglandin-related type of effects, like you can see in renal colic. So as a prostaglandin type of inhibitor and all these other things, it has multimodal efficacy. Haloperidol, this is great for nausea. It's probably not bad for nausea. You can use it due to its anti-dopaminergic effects. Sometimes for chronic abdominal pain or people who have some type of other physical or psych association with abdominal pain, it has been used in some degree with success. So something going forward we may think about using rather than just giving someone fentanyl or morphine for abdominal pain. And it does help for nausea. Down here it does say cannabinoid-induced hyperemesis, so you can use it for that, but we'll talk about something a little bit later that you can use as well, which you probably already all know, this capsaicin cream. These next couple of slides are near and dear to my heart. This is about harm reduction. So what's important to note about this is that this ALTO project is really important. We're trying to limit opioids because, like Dr. McCabe said at the beginning, we are part of the problem. And good recent studies do show that emergency medicine single prescriptions for opioids does indeed increase the chance of somebody being opioid dependent. There was a great article that came out, I believe, in the Journal of Emergency Medicine that showed people opioid naive who both came in for lower work-related musculoskeletal low back pain. Both groups were equal. One group got opioids, the other group did not. 1 year later, the group that got opioids was still more likely to be on opioids, had more missed days of work, had more MRIs, had more surgeries. So that's us. That is us doing stuff. That is us doing harm when we were trying to do good. Not saying not to give it, but musculoskeletal low back pain, when your back ache hurts, should not be getting opioids anymore, right? So here's what's important to know is that we do need to be part of the solution. And one great thing about all of us in emergency medicine is we are the people who take care of society no matter what. We don't care where you are, who you're from, how you pay, we're gonna take care of you. So we need to be part of the solution as well. So I really like to talk about harm reduction here. And harm reduction really just means, how do we reduce your harm? Where do we meet you where you're at, right? So what I say about that is do we treat addiction as a medical condition? Do you? Do you honestly take a patient who's let's say is an addict, an IV drug user, and do you treat them differently? Probably a lot of people do, even subconsciously. Do you think it's a medical condition? You know, I think that if you don't think it's a medical condition, you should probably rethink your thinking a little bit. You know, addiction, we say, is a brain disease, right? And if you don't know how to shoot heroin, that's a weird question to put up there, but like, it's weird, right? But like, know like what your patients go through. So in other words, like, do you use dirty needles? Do you share them? Do you need clean needles? Do you shoot a lot of drugs you don't know where they come from all at once? Like, talk to your patients a little bit. Like, we're healthcare providers, make them safer, right? Like, learn the places where people can give them clean needles, right? Like ACR, right? Or a lot of pharmacies will give them to you. So it's important to talk to them about these things. Do you counsel them in IV drug use? A lot of them don't really know that you can get an epidural abscess and never walk again, right? Like, talk to them about it, right? SAPs, or these are addiction, place of addiction treatment, right? Do you know where the treatment places are where you live? Like, we have a ton in here. Actually, believe it or not, in this area. There's a lot. No one should leave an ER with a piece of paper that says, here, call one of them. Shouldn't happen anymore. Prescribing naloxone. You all should know that you can prescribe naloxone. All the Medicaids cover naloxone 100%. And so you should prescribe any patient that you think's at risk for opioid misuse or drug use. You should prescribe them naloxone. And does your ED dispense naloxone? Some EDs do, some don't. We do at Upstate Hospital. So if you come in with an overdose or drug-related problem, we will give you a naloxone or Narcan to you or your friend or family member who's with you. And that just gets provided by the state. All things to think about. I'm not saying you have to do all of these, but if you don't do any of them, you should try to adopt at least one of them. Do you screen for these things in the ER? If someone comes in for something completely unrelated, are you screening them for addictions or substance use disorder? I talked about facilitating MAT, that's medical assisted treatment. So where can these people go for help? Initiating BUP in the ER, we started Upstate really the first ER in any distance to do it. And now I can say Kraus is doing it, which is awesome. And I would love all ERs for someone who's in withdrawal. You can give, by law, a dose of BUP to anybody in withdrawal without a waiver. You can just do it, by law. You can do it for up to 3 days in a row without having a waiver. And do we do a good job? So our patients are addicts. Like, are we really doing these guys, or women, are we doing a good job with them? All things just to think about. There's so many little pieces in there, you can make a big difference just by doing one little thing, right? Just by prescribing naloxone. Like, that's why some overdose death rates, like in this county, they've gone down a little bit. It's not because people are not using drugs, right? That's because a lot of these harm reduction things and people are getting medications, people are getting help, people are using Narcan. So it's important to still continue with that solution.
Our next goal is to bring this back and bring strategies back to implement this in your emergency department. This obviously is going to require training and teaching. It's pretty straightforward what we're putting together here, though. We're not requiring dramatic shifts in either knowledge, education, or the application of particular materials. This is pretty straightforward what we're asking. This is systemic and systematic changes, and this is going to be a lot of work at first, and then eventually, a couple of years from now, we will reap the benefits of all of this, because once you start having this kind of change, it happens in Colorado, it's happening north of I-90, it now becomes not only a cultural change in medicine, it becomes a cultural shift in patient expectations. and what is deemed as good care and poor care, and how we delineate that in a patient's mind. No longer is it mean I'm caring for you because I push morphine to you. It now means I'm caring for you because I know all the opiate-sparing medications I can utilize for you. But that takes time and will come with frustration and barriers and angry, loud patients in the interim. But cultural shifts don't come easy, they take work. All right, so we looked at some of the probable barriers at your institutions. You can probably look here and pick out the ones that apply to you. Whatever this is. There's going to be particular ones. There's going to be procedural sedation versus pain dose. So something like ketamine is 0.2 milligrams per kilogram defined by European T Committee to be procedural sedation. Or is ketamine just always definitionally procedural sedation, even if it's not? Is it going to be that you don't do injections and blocks in the ER? That's for the pain service. You ER physicians can't possibly do that. That's a pain service. Is it high risk to give ketamine or lidocaine? I'm still fascinated that my dental hygienist can give me nitrous oxide, but I can't, as a physician, give it to patients in my emergency department. So there's lots of interesting things. So a lot of different scope of practice, some training experience, and who does what. So your institutions are going to have barriers. Our institution has barriers. We erect them and then jump over them all the time, and then they blame us for having to hoop over them. The good thing about what we've constructed and what Iroquois and Dr. McCabe and the state has constructed is this is a giant consortium. It is not your hospital alone going at it with these protocols. So it means there's safety in numbers. Again, as Dr. McCabe referred to before, Colorado was very wise in how they did this. And you can hear a lot of the podcasts from the emergency physicians in Colorado who actually started this. They were wise in thinking people will hospital shop. And I know I can go to X, Y, and Z and get my X, Y, and Z. And I know if I go there, I get that. What we're trying to do is bring a geographical change and say there's a consortium of hospitals now all doing the same thing. Now, there's multiple different ways of doing what we're implementing, and I'm going to give you a litany of options, and so is Dr. Sullivan when we get to the options on the medications that we're giving. But at least we know that in these hospitals, our front line for these particular defined clinical conditions are not opioids. All right. Musculoskeletal pain. Here we're really talking about sprains, strains, back pain. A lot of this really is musculoskeletal back pain. So the evidence over and over again here is pretty clear from multiple studies in annals and multiple studies in academic emergency medicine that says opioids for back pain do nothing better than ibuprofen or acetaminophen. And since they do nothing better than, there's no reason to give it. And there's certainly good evidence of prescribing doesn't make a difference, and there's good evidence that one-time doses probably don't make a difference either. So we added some things in here. So ibuprofen 600 milligrams, ketorolac IV. Ketorolac is, as we all know, essentially magical ibuprofen. It's the same thing, only it's parenteral. So you'll have people that are vomiting and retching when we talk about renal colic pain, and there's no evidence that in renal colic pain ketorolac does any better than Motrin, but certainly vomiting people don't do good with PO medication. So we gave this as an option. I use IM. There's good evidence that 15 milligrams, as Dr. Sullivan said, is no better than 30 milligrams, which means no worse than, so there's no reason not to start with 15 milligrams. Has a lower side effect profile than does 30 milligrams in terms of gastrointestinal and renal side effects. If that doesn't work, or we left you some things for spasm, we left diazepam here. Now, the Colorado protocol was real heavy on benzos all over their guidelines. And when we talked about this, we don't want to replace one epidemic with another. And there certainly is an emerging epidemic as opioid prescribing goes down. Benzo prescribing has gone up and is filling its stead. And we've really tried to be restrictive with benzo prescribing, be acutely aware that benzos are just as addictive and just as dangerous as opioids, just not as commonly abused right now. So we did leave diazepam on here for emergency department spasm, not for prescribing. When I started in residency, it was everybody got Percocet for back pain, and then it became, well, there's spasm, so people were getting discharged home on Percocet Valium, and I would look at these scripts my resident would bring me. I'm like, you're consciously sedating this human at home? So now at least we understand that there are things that Dr. Sullivan talks about, there being benzodiazepine receptors in the muscle, so we do know it does potentially reduce acute spasm, but there's no good evidence that it does anything in the long term. So one dose in the emergency department, totally fine, I think. Here, we're not talking about prescribing. You can use cyclobenzaprine. I have never had good luck with any of the antispasmodics, or I should say like Flexeril and what have you, cyclobenzaprine, the same thing. Then we gave you some rescue medication down here. Ketamine. Ketamine's going to be ubiquitous throughout our slides because it's just good evidence as an opioid-sparing parenteral analgesic. There's great evidence, and again, the dose always that we are talking about for the purposes of talking today are 0.1 to 0.2 milligrams per kilogram, slow IV push, or slow IV drip. The trouble you get into with ketamine is usually rate related, and how fast you push it is where you get into more trouble. There's a body of evidence right now about agitated delirium with ketamine, and almost all of it shows pre-hospital agitated delirium. Ketamine winds up with higher rates of apnea than I anecdotally and many of us have experienced in the hospital. And I think it has to do with rapidity of push and EMS having an acutely agitated patient that's dangerous, and they get quicker pushes, I would suspect, is my theory about it, because we know that slower pushes don't have the same association with apnea. The rate of infusion also seems to decrease your rates of masseter and or laryngeal spasms, so we're talking about really low doses in a drug with a really gigantic therapeutic window. Gabapentin is a possibility here as well. We talk about trigger point injections. I've done them a couple times. I think they're good if you're using them already. Ketorolac, and then up here, we left it out because of cost, but lidoderm patches as well are another possibility here. I use lidoderm patches in my emergency department with good success. The issue I have with it, I'm sure you all do, is then sending somebody home on a lidoderm patch and the cost and prior auth nonsense that we don't do.
Every once in a while, I still will go somewhere, work somewhere, and I'll see someone coming with a migraine or headache, and they're getting opioids. And we talk about there's quite a bit of literature that suggests not only do opioids actually not work, I'm going to say it straight up, they don't work. They also cause rebound migraines and headaches. And that's, our neurologist spend a lot of time preventing rebound headaches. So we are not, opioids shouldn't be used for this. There's a lot of medications on here that you can use. Now in our hospital, it seems like every place has kind of like their go-to, algorithm, so to speak. And we normally start out with like fluids, Raglan, first. Like that's kind of like our go-to, like an antidopaminergic. And then Ketorolac as well, normally we have in there as well. So someone comes in with a migraine, do you give them ibuprofen, acetaminophen, or Ketorolac, acetaminophen, some fluids, 10 milligrams Raglan, and you're gonna wait to see how they're doing. I very rarely, if ever, use sumatriptan for migraine headaches, but some people apparently do quite a bit, so we left it on there. Most people, I think, who get this are people who are like they're frequent flyers for migraine to say, my neurologist, we've come up with this plan, I get sumatriptan every time. So we leave it on there for that group of people. And then, like a lot of our migraines, this stuff takes the edge off or maybe doesn't work at all, and then you got to go to the next few things. And the next thing that we normally talk about are some vasculature stabilizing agents. So we'll use intravenous magnesium. We'll use dexamethasone really to prevent kind of the rebound migraine or the migraine that might come secondarily. Caffeine's on there. For those of you people who've used caffeine, valproic acid is something that's actually grown pretty popular for using for refractory migraines or headaches. Certainly you can use a second dose Raglan. That's kind of what I do a lot of times is I use Raglan, all this other stuff, fluids, an NSAID, and then if it doesn't work, I often will do a second dose of Raglan. You can plus or minus diphenhydramine. A lot of data says that giving intravenous diphenhydramine really doesn't increase or decrease the incidence of extrapyramidal effects. But sure, you can do it. You can also give oral because IV is on shortage now. So you can also give it oral if you wanted to. One of the things we talk about are sphenopalatine block, where you can actually, up in the nose insert like an anesthetic type right up into the top of the nose where the sphenopalatine area is, or the actually occipital block. So it's funny, if you actually look at these videos, these occipital blocks are actually relatively easy. And, I've done them a few times, and you could use anesthetic or steroid, and people really do pretty well with some of these occipital nerve blocks. However, most of the time, an array of these medications seems to work for headaches and migraines. I would assume most people aren't using opioids for headaches and migraines anyways, and you probably have your own way to do this, but for those places that don't, we wanted to put this on here.
Yeah, I think it's important that we remind ourselves that migraine is a neurological disease that has painful manifestations. And so some of those medications that Dr. Sullivan is talking about are the same, they're working through those same pathways. Opioids just don't have any of that thing. When we're talking about anti-epileptics, or we're talking about steroid, we're talking about ways of preventing these spreading depression and the problems that occur with migraine headache, whose manifestations result in things like vasodilation. But those are the end result, and we're treating the underlying problem, which is the nerve disorder that causes the painful condition. So abdominal pain, again, drawing a distinction as I did earlier, I'm not telling you that your first line treatment for your perforated ulcers are haloperidol, though sometimes it does help. I have to be honest with you. But what we're really looking at is chronic abdominal pain individuals that come in. Kids, we call it functional abdominal pain. Adults, we call it cyclical vomiting syndrome. We call it abdominal migraine. We call it cannabinoid hyperemesis syndrome if we have the right association. But in all of these things, there certainly seems to be a nervous component. And I'm saying nervous not in the antiquated like nerve, but a nervous system component that's providing this discomfort. And all of these medications will work to mitigate for that. We know that abdominal migraines and chronic functional abdominal pain and cyclical vomiting syndrome respond to the phenothiazines like haloperidol. And we know that from experiments, we know that from data. So these individuals may ask for things like opioid medications because they've been indoctrinated by us that that's what treats their pain, but really that's what masks their pain. These medications are what treat their pain, at least as far as we can tell in 2018. So we're trying to treat the underlying etiology of the pain. Opioids mask, they don't treat anything. So what we're looking at here are things like haloperidol, metoclopramide, diphenhydramine, or I don't use much dicyclamine. I think for my irritable bowel syndrome I've used it a couple times, but my own personal irritable bowels. But no, for my patients with irritable bowel syndrome I've used it a couple times, but I don't tend to use it that frequently. But there's good evidence that these medications as frontline agents make a difference. Now we put rescue medications over here. In a couple of places we kept lidocaine on. I do not have much good experience with intravenous lidocaine barring cardiac arrest. So I don't know that the evidence is exceedingly strong for intravenous lidocaine for painful conditions, but we kept it on there. Apparently Colorado's had good experience with it. I don't have good data to tell you their good experience is as good as they purport it to be. The only data I have is in renal colic, and it's equivocal in renal colic for any kind of pain medication, so there's still clinical equipoise. So I don't know, but we left it on here as a rescue medication. And the other thing to point in here, cannabinoid hyperemesis syndrome, it's one of our few resident claim to fames that I have. My former chief resident went off and did his residency with us and then did his fellowship at Bellevue, and he's only interested in cannabinoids recreationally and professionally. And so what he found was looking at the data, looking at capsaicin for the anterior abdomen, because the substance P induced kind of this reinforcement of this vomiting that capsaicin put on the anterior abdomen in real cannabinoid hyperemesis syndrome seems to work. They just kind of happened upon this by finding that people who took hot showers, who used cannabinoids every day, felt better with their hot showers and hot baths, and then very smartly decided to try it with a chemically induced capsaicin. This usually takes me a while to get from the pharmacy. I've given it to people that's had no effect on, and they just complain to me that their belly burns, but I'm like, oh, now you're not thinking about your vomiting, are you? So potentially here, again, diphenhydramine seems to have some anti-nausea, anti-vomiting properties here. It's on back order here, but what we're saying is in these individuals who quantify in a particular way, these medications have been proven to be efficacious in them over and over again. I'd caution you on doubling up things like haloperidol with metoclopramide for extrapyramidal side effects, but otherwise there's good evidence that the combination is pretty efficacious with things like haloperidol and ketorolac.
All right, I think this one's pretty straightforward and easy. This is renal colic. Really, we are, I mean, compared to what we normally give, we're trying to give Tylenol and Motrin for a kidney stone. Has anyone ever had a kidney stone in here? A lot of the data does suggest, though, and indeed you can give, interestingly enough, ketamine, and really the point is, someone comes in, you're going to order some, acetaminophen. We have intravenous on here because there is some data that supports intravenous. Acetaminophen has a good reduction in pain in postoperative patients. It is expensive, so it's and there are some pharmacies and toxicologists sometimes get nervous about this because any potential maybe toxic effect, based on if they've taken the oral acetaminophen before they came in. But nonetheless, so acetaminophen and ketorolac, IV or intramuscular. We have with or without, fluids. There's a lot of data that supports that these people get overly fluid resuscitated and actually becomes kind of detrimental to them, and it's not good for them. But 1 liter of normal saline in most adults would prevent or be any problem whatsoever. And then if they're not really having, what we want is a stone to move a little bit, right? Like we talked about yesterday. I mean, the stone can move literally, millimeters or 0.5, 0.1 millimeters, and pain gets much better or pain gets much worse. So really we're just trying to kind of modulate the pain a little bit, see if we can pass the stone or move the stone. Obviously, if pain continues beyond acetaminophen fluids and 1 or 2 doses of ketorolac, we would actually recommend ketamine here. And this is one of the, I think, ailments where you could actually probably use ketamine more than a lot of the other things. If you look at the other things we've looked at, there's a lot of other medications that we can use. Like headache, we had 20 medications on there, and abdominal pain, even musculoskeletal. But here it's Tylenol, or acetaminophen, and NSAID, and then really the next step we would recommend is ketamine rather than just using opioids. Good data for ketamine. Lidocaine is actually, talk about lidocaine, it actually causes direct lidocaine anesthesia to the renal area, to the renal tubule area. That's how its proposed mechanism is. Causes some anesthesia at the area locally, directly with lidocaine. The data's, some say they've had some success, some say they haven't had success. I tried it once for fun on a patient. That sounds bad, but didn't really do anything. It is safe though, and it's very quickly metabolized, right? So giving a dose of intravenous lidocaine, that's why we use our cardiac arrest, it's there and gone. But ketamine does work, and I have used this many times for people with renal stones, and it's worked pretty well. Again, massive stone, infection of the kidney, nausea, vomiting, hypotension, that's different. You might want to use something else, but ketamine can still be used.
With the opioids masking pain and the other medications treating pain, remember these people are in pain because they have prostaglandin-induced ureteral spasm, and Toradol, ketorolac, actually is reducing that. So you're actually reducing the reason that they're in pain in the first place, which is the spasm. And you're getting rid of that with the ketorolac. It's actually treating the cause of the pain. So it has dual properties here, both its analgesic property as an anti-inflammatory and its anti-inflammatory properties reducing the spasm in the individual that's coming in. Last is quite easy. Dental pain never needs opiates in the emergency department. That's just a blanket statement. I will tell you that because the data says the same thing. Over and over again, the data says that no better. The 2 things I would tell you that are best studied are musculoskeletal back pain and dental pain. Over and over again, there's multiple studies, probably because it's low-lying fruit in terms of figuring out these studies. What we would recommend is ketorolac, acetaminophen. What I would really strongly recommend are dental blocks. People with real, honest-to-goodness dental pain. And Dr. Sullivan talked yesterday about dental pain being a marker sometimes for substance abuse, and we know that. There are certain people that have, but there are also, we give benefit of the doubt. There's lots of people who have bad dental pain. They'll come in for you, and they want relief. And how you can relieve them is with a block. A block makes a difference. Again, if you don't remember your inferior-alveolar block or whatnot, I think it's fine because an apical block is the easiest thing in the world. You pull back the buccal surface, you aim at the gingival reflection, and you hit the root essentially, and inject 1 to 2 cc's of bupivacaine, and that tooth will not be felt for the next 8 hours, hopefully in time to get them to a dentist. We're looking for kind of basic things here. We're looking at blocks. These are pretty straightforward things.
Next, I want to take you through this document, which I think you all have at your tables. As I think through the end of the day and saying, well, how does this group kind of go forth and get this message embedded in your providers and your emergency department and your practice, the way is with tools that will come from Iroquois. And I think in some ways this may be the real document that's going to be easiest to have lying around your department, passed out at nursing meetings, passed out at department meetings. So let me just walk through what's in here and why we've put it here. So if you open this up, the first page introduction is just kind of to run through what the project is. On the next kind of 2 open pages is the podcast series and the videos. And Ross and Bill kind of went through and found most of these for us. And I think they're very good. We recognize that some of your providers may say, oh, this is really helpful. I'll go home and tonight I'll listen to an hour-and-a-half podcast. And some may say, I don't have time for a podcast. So we recognize there's going to be a variety of ways that people are going to pick up the information, learn from what you've learned and what you're trying to get people to do. So we're just giving you options. The podcasts come from the Emergency Medicine Minute series. And I've listened to them all. They're good podcasts. Some of them are a little bit lengthy. but I think they present very useful information. I think obviously part 3, the alternative to opioids from Emergency Medicine Minutes, is probably a key one if you want to say, as you teach people, point out to one of them that they ought to spend the hour on. There's a multitude of videos out there, and these are just a couple of selected examples around trigger points and occipital nerve block. But you know, we talked a little bit about blocks in the protocols, and I think most people who've done them would say they're very useful. Most people who haven't done them would say, well, I don't know how to do them. And so it's pretty easy to learn most of these simple ones. And even as Bill said, even learning to do a femoral nerve block under ultrasound is not that hard if somebody can teach you to do it. So I think there's a multitude of videos, and the injections, whether it's trigger points or blocks, are useful, so we want to at least include them. If you turn to the next page, it says selected references, and they really are just that. They're selected references. If you go to the Colorado ACEP materials, you'll see a much more extensive list of references. And so again, it's CHA.com. You would think it's CHA.org, but it's not. It's com. And then there's a little spot for ALTO project, and you'll see all the training materials there, including the Colorado ACEP guidelines. And if you want a more extensive reference list, they're there. But this is, I think, a pretty good starting point. There's a page that says Opioid Alternative Project Treatment Guidelines. And this is the same stuff that's in the pictures. It's presented a little bit differently and might be useful to kind of hang or post somewhere, because it kind of organizes around first approach, second approach, and other things you might do at your discretion. While the pictures are fine, we think this is just another way that lets people kind of operationalize the picture guidelines that we put in the book. And then the next page has the protocols or guidelines that you've seen in pictorial form for the 5 entities that we've picked. There is a drug dosage, drug and reference table. And again, we've tried to be consistent in using the generics throughout. We put trade names. We've put usual doses and available routes. I think we've captured most everything. We've put the usual disclaimer that what you give is up to you, not to Iroquois. We think the list is pretty accurate, but obviously this is there for reference, and people need to guide themselves. And then lastly, Ross talked a little bit about reducing opioid prescription and use after the ED visit, which is not the primary goal, but certainly we hope and expect will be a secondary goal. And so there is a page on pain-free options by indication at discharge. So we hope this document will be kind of the most useful document for you for quick and dirty use with your staff back home.